Welcome to the deep dive. Today, we're getting into some really fascinating stuff, advanced medical imaging for vascular diseases.
We are. We're drawing from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, specifically the chapters on vascular PCT and SPECT CT.
Right, and the goal here, for you listening, is really to cut through the jargon. We want to explore how these techniques give us a much deeper look inside blood vessels.
Yeah, it's about going beyond just the shape and size, getting into the actual physiology, what's happening at a molecular level.
Exactly, like traditional imaging shows us the pipes, right, the structure.
hmm
But PT and SPECT CT, they let us see the activity inside those pipes. Things like inflammation, early warning signs.
And that's the key, isn't it? Seeing those physiological changes, often before the structure itself looks dramatically different. It's non-invasive, too.
Which could mean catching problems earlier, intervening sooner, maybe better outcomes down the line.
That's certainly the hope and the driving force behind a lot of this research.
Okay, so let's start there. What are the main shortcomings of the traditional ways of looking at blood vessels? Why do we need these newer tools?
Well, like you said, the conventional methods, think ultrasound, CT angiography, MRI, they're really good at showing morphology, structure.
Blockages, narrowing, aneurysms, that kind of thing.
Exactly. They map out the anatomy very well. But they often miss the very early stages of disease, the physiological stirrings, if you like.
Like inflammation.
Inflammation's a big one, yeah. It can be brewing in the vessel wall, maybe setting the stage for a plaque to become unstable, but it might be totally invisible on a standard angiogram until it causes a significant narrowing or change in shape.
So we're aiming to catch the trouble before it becomes a big structural issue, which brings us
Yeah.
to molecular imaging. What's the basic idea?
The core concept is using these special molecules, radiopharmaceuticals, or tracers. We introduce them into the body, usually an injection.
Okay.
And these tracers are designed very specifically to latch onto or get taken up by certain biological processes happening at the cellular level.
So they're like tiny spies reporting back on specific activities.
That's a great analogy, actually. They could target, say, cells with high metabolism, like inflammatory cells, or areas where calcium is being laid down in plaques.
And the radio part, that's how we track these spies.
Precisely. They emit a very small amount of radiation. Not enough to be harmful in these diagnostic doses, but enough for sensitive cameras, gamma cameras for SPECT, PET scanners for PET to detect.
And the big win is seeing these processes happen in real time.
Yes, visualizing the function, the physiology, often way before you'd see a lump or bump on a traditional scan. Early detection.
Okay, SPECT D and PT, you mentioned both. What's the difference? And then where does the CT fit in?
Right, let's break that down. SPECT-T stands for Single Photon Emission Computed Tomography. Here, the tracer emits single photons, kind of randomly.
Okay.
Gamma camera rotates around you, picks up these photons, and reconstructs a 3D image of where the tracer went. But the resolution isn't super high, and sometimes signals from different depths can overlap, making it a bit blurry, lower contrast.
Got it. A bit less sharp.
Yeah. Now, PET positron emission tomography uses tracers that emit positrons. A positron is like an anti-electron.
Whoa, okay.
When it bumps into an electron nearby, and there are plenty of those in your body, they annihilate each other. Poof.
Annihilate. Sounds dramatic.
It is, at a tiny scale. But what's key is that this annihilation creates two photons that shoot off in exactly opposite directions.
Okay.
PET scanners are designed specifically to detect these pairs of photons arriving at opposite sides of the scanner at the same time. This coincidence detection allows for much better localization.
So a more precise signal.
Much more precise, better spatial resolution. We're talking maybe 3 to 4 millimeters. Plus, PET tends to be easier to quantify. We can calculate something called an SUV, standardized uptake value.
SUV, like the car.
No. It's basically a measure of how much tracer has accumulated in a specific spot, corrected for dose and body size. It gives us a number, a quantitative measure of the metabolic
Oh,
activity.
it's useful. Numbers are good. And you mentioned fluorine 18.
Yes, 18F is a very common positron emitter used in many P tracers.
Okay, PT sounds like it has some advantages. Better picture, quantification. Now the CT part, why add that?
Good question. Because both SPECT-DAN and PET, fundamentally, they show you the function, the metabolic hotspots.
The what's happening.
Exactly. But they don't give you a super detailed anatomical map on their own. You see a blob of activity, but is it in the vessel wall next to it in a lymph node?
Right, the where is missing.
That's where the CT computed tomography comes in. CT uses X-rays, gives you that detailed anatomical picture, the structure.
So you fuse them.
Bingo. Modern scanners combine PT or SPECT with a CT scanner in the same machine. You get both scans almost simultaneously. The computer then overlays the functional PT or SPECT image onto the anatomical CT image.
The hybrid approach, SPECT TCT or PET-T.
Exactly. And it's brilliant because you get the best of both worlds. You see the functional abnormality and exactly where it is anatomically.
That must really boost diagnostic confidence.
Immensely. Improved sensitivity, you can spot subtle uptake in small structures. And specificity, the uptake is actually in the structure you care about, not just nearby. Plus, it's convenient for the patient, one appointment, and ensures the functional and anatomical data are perfectly aligned. Might even reduce overall costs sometimes.
Makes total sense. Okay, let's talk tracers. These molecular spies. What are the main ones used for looking at vascular problems?
Well, probably the most widely used one, even vascular imaging now, is 18F-fluorodeoxyglucose, FDG.
FDG, I've heard that mentioned a lot with cancer scans.
You have. Because cancer cells are often highly metabolic, they gobble up glucose. FDG is basically a glucose mimic.
So it looks like sugar to the cells.
Pretty much. Cells take it up using the same transporters they use for regular glucose, especially cells that are very active, like cancer cells or, and this is key for us, inflammatory cells.
Ah, okay. So inflammation means high activity. It means high glucose need.
Exactly. Activated white blood cells, leukocytes, monocytes, macrophages, lymphocytes, they all ramp up their glucose metabolism when they're fighting infection or involved in inflammation.
So they take up the FDG.
They take it up, and an enzyme called hexokinase acts on it, just like it would on glucose. But the FDG molecule is slightly different. It gets phosphorylated, but then it gets stuck. It can't go further down the metabolic pathway.
It's trapped inside the active cell.
Precisely. So areas with lots of active inflamed cells accumulate a lot of FDG, and they light up brightly on the PT scan. It's a marker of metabolic activity, which in the vascular system often signals inflammation or infection.
Okay, FDG for inflammation and high metabolism. What else is common?
Another important one, especially gaining traction in vascular imaging, is 18F sodium fluoride.
Yeah. Sodium fluoride, like in toothpaste.
Sort of the same fluoride ion, yes,
Okay.
but radioactive 18F attached. Its main established use is actually bone scanning. Because fluoride ions get incorporated very readily into the mineral matrix of bone, especially where active bone formation or turnover is happening. It gets taken up quickly by bone and clears rapidly from the blood, giving really nice bone images.
Okay, but how does that help with blood vessels?
Well, it turns out that NAF also accumulates in areas of active calcification within atherosclerotic plaques.
So not just existing calcium, but where calcium is actively being deposited?
That seems to be the idea. It's targeting the process of microcalcification, which might be linked to plaque instability.
Yeah.
And a potential advantage over FDG, especially for coronary arteries,
Yes.
is that NAF has very little uptake in the heart muscle itself or in normal blood vessel walls. FDG uptake in the heart can sometimes make it hard to see uptake in the nearby coronary plaques. NAF avoids that issue.
Interesting. So FDG for inflammation, NAF potentially for active calcification. What about labeled white blood cells? You mentioned SPECT earlier.
Right, leukocyte scintigraphy.
Yeah.
Using the patient's own white blood cells tagged with a radioactive tracer, usually indium-111 or technetium-99 meter. That sounds complicated.
It is more involved, yeah. You have to draw the patient's blood, send it to a special lab to separate and label the white cells, then re-inject them.
Bit of a process.
Definitely. And you often need to image at multiple time points, say 4 hours and 24 hours, to see where they migrate. But it's still considered a gold standard, really, for nuclear imaging of infection, especially musculoskeletal infection. Very accurate if done right.
And its role in vascular?
It's used particularly for suspected vascular graft infections, which we can talk more about later, but the complexity and time involved are limitations.
Okay. FDG, NAF, labeled white cells. Are there others being explored? The chapter mentioned quite a few.
Oh, absolutely. Research is buzzing in this area. People are developing tracers to target all sorts of things involved in atherosclerosis.
Like what?
Things like labeled LDL, the bad cholesterol, or oxidized LDL, which is thought to be particularly nasty in plaques. Antibodies targeting specific molecules on inflammatory cells. Tracers for platelets or fibrin to look for blood clots within plaques.
Yeah, annexin V to detect dying cells, apoptosis.
Mhm.
Ligands for receptors found on activated immune cells like T lymphocytes, IL-2 receptors, or macrophages, translocator protein, somatostatin receptors, even tracers like choline that macrophages also take up. matrix metalloproteinases, MMPs, enzymes that chew up tissue and might destabilize plaques. And off it goes on.
It sounds incredibly complex, trying to tag every little step in the process.
It really highlights how complex atherosclerosis is.
Hmm.
But a key takeaway from the reading, and it's important for you listening to know,
Yes.
is that despite all this research and these different potential tracers, none of them, apart from FDG and perhaps NAF in certain contexts, are really in widespread routine clinical use, specifically for identifying vulnerable plaques, the ones likely to rupture.
So still mostly research tools.
Largely, yes. They face challenges. Maybe they don't clear the blood fast enough, or the signal from the plaque isn't strong enough compared to the background noise, or they bind non-specifically elsewhere. So there's still a big need for better, more robust clinical tools for plaque imaging.
Understood. A lot of potential, but work still needed. Okay, let's shift gears. How are these techniques actually being used now in clinical practice, or close to it, for specific vascular conditions? Let's start with atherosclerosis, the big one.
Right. Atherosclerosis, plaque buildup. FDG-PTT has given us some really valuable insights here. Studies have shown, for instance, that FDG uptake increases in the carotid arteries, the big ones in your neck, with age, in men, and in people with traditional cardiovascular risk factors.
Like high blood pressure, high cholesterol.
Exactly. It links inflammation, as detected by FDG, with known risk factors.
Is there evidence linking this uptake to actual clinical events like stroke?
Yes, definitely. A key early study by Rudd and colleagues looked at patients who'd had a TIA, a mini stroke, or a recent stroke caused by carotid artery disease.
Okay.
They found significantly higher FDG uptake in the carotid plaque on the side that caused the symptoms compared to the plaque on the other side. And importantly, when they examined the plaques surgically removed from these patients, the areas with the highest FDG uptake on the scan corresponded directly to areas packed with macrophages, those inflammatory cells.
Wow, a direct correlation between the scan signal and the cellular inflammation.
A very strong link. And other studies using combined PD-MRI have found increased FDG uptake in plaques of patients who've had strokes, even in plaques that weren't causing severe narrowing.
So it's not just about how blocked the artery is.
Precisely. It's about how angry the plaque is, how inflamed. Plaques considered unstable on ultrasound or MRI, those with a large lipid core, internal bleeding, or that look dark on ultrasound, they consistently show higher FDG uptake.
So FDG-PTT helps identify the potentially dangerous inflamed plaques, not just the big ones.
That's the crucial idea. It's adding a layer of biological information to the anatomical picture. We also see correlations between carotid FDG activity and blood levels of C-reactive protein, CRP, and another inflammation marker.
Suggesting a systemic link.
Yes. And higher uptake is seen generally in the vessels of patients with multiple risk factors, existing coronary disease, type 2 diabetes, metabolic syndrome. It paints a picture of overall vascular inflammation.
Can we use it to see if treatments are working? To track inflammation going down?
That's another major application being explored. Sequential PT-CT scans can monitor the effect of treatments. Animal studies showed certain drugs could reduce FDG uptake in plaques.
And in people?
Yes. Human studies using statins, like simvastatin, have shown reductions in arterial wall FDG uptake over time, alongside the expected drop in LDL cholesterol. This inflammatory reduction might happen even before you see significant structural changes on, say, MRI.
That's interesting. So the metabolic change might precede the structural one.
It seems so. And interestingly, significant lifestyle changes like diet modification have also been shown to reduce the extent of FDG-positive vascular regions.
That's really powerful, seeing a direct impact of lifestyle on vessel inflammation. Now, you mentioned NAF before for calcification, but the chapter also talks about FDG uptake and calcification sometimes being seen together. How does that work? Isn't SCG about inflammation?
Yes, that's a complex but important point. You can see FDG uptake co-localizing with calcified areas on PT-CT. But the relationship isn't straightforward.
Okay.
Researchers have seen different patterns. Some calcified plaques show no FDG uptake. Some show both. Some show FDG uptake, but have no calcification visible on CT yet.
So it's not a simple one-to-one thing?
Not at all. It probably reflects different stages of the atherosclerotic process. A heavily calcified plaque seen on CT might represent older, more burnt-out disease, perhaps less actively inflamed.
You're right, scar tissue, almost.
In a way. Whereas FDG uptake, even if there's also calcification, likely points to ongoing active inflammation, maybe related to those microcalcifications NAF picks up, potentially indicating a more unstable situation. Some studies even find no correlation, or a negative one, between the amount of calcium and the intensity of FDG uptake.
So CT shows the history, calcification. PET shows the current activity, inflammation.
That's a good way to think about it. They provide complementary information about the plaque status.
And does this inflammation change over time?
It seems to. Studies following patients with repeat scans show that vascular wall FDG uptake can fluctuate. Inflammation might be more of a transient feature, waxing and waning, while calcification is more of a cumulative, chronic marker.
Which has implications for trials testing anti-inflammatory drugs.
Exactly. You need to capture that dynamic process.
Okay. Now, imaging these plaques isn't always easy, right? What are the challenges?
Definitely challenges. Plaques can be small, really pushing the limits of the scanner's resolution. Some arteries, like coronaries, are deep inside the body and they move constantly with heartbeat and breathing.
Motion artifact must be a problem.
It is, especially for coronaries. Requires sophisticated techniques to manage. Also, as we touched on, some tracers, especially older SPECT agents, have issues like slow blood clearance or nonspecific binding, making the images less clear. Finding that perfect tracer for routine vulnerable plaque imaging remains a hurdle.
So still some technical hurdles and tracer development needed for widespread use, especially for vulnerable plaque.
Yes, particularly for routine clinical decision-making, based solely on these scans for plaque.
Let's touch briefly again on the other tracers mentioned for plaque NAF, LDL, antibodies, etc., just to recap their potential roles.
Sure. NAF, as we said, targets active calcification. Labeled LDL or oxidized LDL aims for macrophage-rich fatty areas. Platelet or fibrin tracers look for thrombus formation. Annex and V looks for cell death. IL-2 for activated T cells. Others like PK, Allomin 195 or dotatate target specific receptors on macrophages. Choline also gets taken up by macrophages.
Lots of different angles.
Lots of angles, lots of research, but mostly still in the research phase for clinical plaque assessment.
Understood. Okay, moving beyond atherosclerosis in general, what about specific aortic problems, like aneurysms?
Abdominal aortic aneurysms, AAAs,
Mhm.
FDG, PACT, has shown increased activity in the walls of AAAs, even asymptomatic ones.
What's causing the uptake?
It's thought to be transmural inflammation through the whole wall thickness with lots of macrophages accumulating.
Does higher FDG uptake mean the aneurysm is more dangerous, more likely to grow or rupture?
That's been investigated, and the picture is, well, a bit mixed. Some studies suggested a link between higher FDG uptake and faster expansion or rupture risk may be related to higher wall stress. But other studies have actually found an inverse relationship, suggesting maybe aneurysms with less metabolic activity are the ones more prone to expanding later. It's complex. However, increased FDG seems more common in smaller aneurysms that are causing symptoms and have clear inflammatory changes.
Interesting. So maybe not a simple more FDG equals worse relationship for growth, but perhaps linked to the symptoms. What about aortic dissection? That's a tear in the aorta wall.
Dissection is also known to have an inflammatory component. Studies using FDG PT-CT in acute aortic syndromes found increased FDG uptake in patients whose condition worsened.
And in dissection itself.
Yes, in type B dissections, those not involving the ascending aorta, higher FDG uptake near the entry tear was linked to worse outcomes, like death, rupture, or needing surgery later.
So FDG might help predict prognosis.
It potentially could. It might help identify patients at higher risk who could benefit from earlier, more aggressive treatment like surgery. But, like with AAA, more clinical data is needed to really solidify its role here.
Okay, potential predictive value, but needs more research. Let's switch to large vessel vasculitis, things like GCA and Takayasu.
Ah, yes. This is an area where FDG-PT-CT has really made a big impact clinically.
Why is it so useful here?
Because in these conditions, the inflammation in the vessel walls often starts before you see significant structural changes like narrowing or thickening on traditional imaging.
So it allows for earlier diagnosis.
Exactly. MRI is good for showing the structural results of inflammation, but FDG-PET can pick up the active inflammation itself very early on in the aorta and its branches. The pattern of which vessels are lit up helps distinguish between giant cell arteritis, GCA, Takayasu arteritis, TA, and others. It can even spot associated things like polymyalgia rheumatica.
So it's become a key diagnostic tool.
Definitely. Yeah. Especially when patients have vague symptoms, like fever of unknown origin, weight loss, just feeling unwell. FDG-PET can often pinpoint the vasculitis when other tests are inconclusive.
How accurate is it?
Studies show high sensitivity and specificity, especially in patients who haven't started treatment yet and have high inflammatory markers in their blood. It's quite sensitive in biopsy-proven GCA too. We see typical patterns. GCA often affects the aorta, subclavian arteries, TA affects the aorta and its main branches.
Any limitations?
Well, it can sometimes miss temporal arteritis, the inflammation of the scalp arteries, maybe because the vessels are small or due to background brain activity. But overall, compared to CT or MRI alone, FDG-PET is often considered superior for early diagnosis and also for monitoring treatment response in TA.
Does the FDG uptake correlate with how active the disease is?
Yes, generally. The intensity of vascular FDG uptake often correlates with blood inflammatory markers like CRP or ESR and GCA. And quantitative measures like SUV can be used to track disease activity during follow-up in TA.
Better than MRI for tracking treatment.
Some studies suggest FDG-PTCT is better than MRI for monitoring GCA during immunosuppressive therapy, showing improvement earlier. It's really useful. Though, one caveat. Interpretation can be tricky if the patient is already on high-dose steroids, as steroids suppress the inflammation and thus the FDG uptake.
That makes sense. And there are official guidelines now.
Yes, crucial point. Major nuclear medicine and cardiology societies put out a joint procedural recommendation paper on using FDG-PTCT in large vessel vasculitis and polymyalgia rheumatica. It standardizes how to do the scans and read them. It's now the internationally accepted standard.
Fantastic. So a powerful tool for early diagnosis, assessing activity, and monitoring treatment with standardized approaches emerging.
Absolutely. It can visualize the inflammation early, potentially preventing serious complications like vessel blockage.
Great. Now another tricky area, vascular graft infections. How does molecular imaging help here?
This is another major application. Diagnosing infection in a prosthetic vascular graft can be really tough with just CT or ultrasound. Molecular imaging helps determine if nonspecific findings on those scans are actually due to infection.
Which techniques are used? Labeled white cells, FDG.
Both are used. As we discussed, labeled white blood cell scintigraphy, WBC, is a classic technique for infection. But FDG-DET is increasingly used and often preferred.
Why preferred?
FDG-PET generally gives better target-to-background ratios, meaning the infection stands out more clearly. The scan itself is quicker, usually done in 1 day versus potentially 2 days for WBC. You don't need to handle the patient's blood, which avoids potential biohazards and complexity, and you can quantify the uptake with SUV values.
But WBC is still considered accurate.
It is, especially with SPECT CT. But it has limitations. False negatives can happen, maybe due to antibiotic use or chronic infection. False positives can occur from sterile inflammation, hematomas, or early post-op changes. Dual-time point imaging helps, but interpretation needs care.
And the hybrid SPECT-CT aspect is important for WBC scans too.
Hugely important. Just like with PTT, adding the CT to the WBC SPECT scan allows precise anatomical localization. You can see definitively if the white cells have accumulated on the graft or just nearby. Improves confidence and helps define the extent of infection.
Okay. What about FDG-PTCT specifically for graft infections, strengths and weaknesses?
FDG-PTCT is very sensitive. It's good at picking up infection if it's there, but its specificity might be a bit lower than WBC, especially soon after surgery.
Why lower specificity?
Because, as we mentioned, non-infected grafts can have some mild linear FDG uptake due to the body's normal foreign body reaction, that chronic and septic inflammation. Healing stars, other inflammatory processes, even nearby tumors can cause uptake.
So how do you tell infection apart from normal post-op stuff?
The pattern and intensity of uptake are key. Intense, focal, or irregular uptake right along the graft is much more suspicious for infection than mild, smooth uptake. And again, the CT part of PTCT is critical. It helps correlate the FDG activity with anatomical findings like fluid collections, gas bubbles, or tissue stranding around the graft. Seeing both together significantly boosts accuracy.
So fusion is key.
Fusion is key. Studies show FDG-PTCT has high accuracy for diagnosing graft infection when interpreted carefully, considering both the PT and CT findings. Comparing P alone versus CT alone versus fused TTCT, the fused images consistently perform best.
Are there guidelines for imaging graft infections too?
Yes, the European Society for Vascular Surgery, ESVS guidelines, endorsed by the European Association of Nuclear Medicine, EANM, provide a workflow. They usually recommend CT angiography first, if that's unclear.
Then molecular imaging comes in.
Yes. For grafts in the chest or abdomen centrally located, FDG-PTCT is recommended as the next step. For limb grafts, if things are still uncertain after CTA, either FDG-PTT or WBC scintigraphy, preferably SPECT-CT, can be used.
Okay, so a structured approach using these tools depending on the situation. Now, broadly speaking, what are the main limitations or risks we should keep in mind with these molecular imaging techniques?
Well, we've touched on spatial resolution. It's good, around 4 to 5 millimeter for PAT, but not microscopic. Hybrid imaging helps localize, but you're still limited by the PET or SPECT resolution
Oh,
itself.
right.
Developing new, better tracers, as we discussed, is a constant challenge. It's a slow, expensive process to get them from the lab to the clinic.
And radiation?
Yes, that's always a consideration. Both SPECT CT and PET TT involve radiation exposure from the injected tracer and from the CT component.
How much are we talking about?
The doses vary, but an FTG-PCT scan might give an effective dose somewhere in the range of, say, 5 to 20 millisieverts, depending on the protocol and the CT part. That's roughly equivalent to a few years of natural background radiation. Technologists and physicians always aim to use the lowest dose possible, the A-layer eye principle, and newer scanners and CT techniques are constantly improving, allowing dose reduction. But it's a factor, especially if repeated scans are needed.
Absolutely. Benefit versus risk. Okay, looking ahead, what excites you most about the future of vascular molecular imaging?
Several things. Firstly, the continued emphasis on multidisciplinary teamwork, vascular specialists, radiologists, nuclear medicine physicians, all working together. That's crucial.
Agreed.
Secondly, continued efforts to standardize protocols for acquiring scans and criteria for interpreting them worldwide. That makes research more comparable and clinical application more consistent.
Makes sense. Like, what about technology?
Hybrid PT-MR is really interesting. MRI gives amazing soft tissue detail without using ionizing radiation like CT does. Combining PT sensitivity with MRI's anatomical and functional capabilities, that holds a lot of promise, especially for things like plaque characterization or imaging the heart and brain. Early studies comparing PT-MR and PT-CT for carotid imaging show good agreement.
Less radiation, potentially more information.
Exactly. And the other huge development, just starting to roll out, is total body PTT-CT.
Total body, scanning the whole person at once.
Essentially, yes. These new scanners have detectors covering a much larger area, sometimes the entire length of an adult. This is potentially revolutionary.
Also,
They can scan much, much faster. Or alternatively, they can scan for the same amount of time but use significantly less radioactive tracer, lowering the radiation dose dramatically. Or they can track tracers over much longer periods, hours even, to see slow biological processes. And they might even achieve better spatial resolution.
wow, that sounds like it could open up entirely new applications.
It really could. Faster scans, lower doses, longer observation times. It changes the game for research and potentially for clinical practice across many fields, including vascular disease.
Very exciting possibilities. Okay, so let's try to wrap up this deep dive. What are the key takeaways?
I think the main thing is that molecular imaging with PCT and SPECT CT gives us this incredible window into the actual processes driving vascular diseases. It's not just anatomy anymore, it's physiology, it's biology.
Yeah, seeing the inflammation, the active calcification, the infection, it allows for potentially earlier, more precise diagnosis.
And helps monitor treatment effectiveness, assess risk in ways we couldn't before.
For me, the real aha moment is that shift from just seeing vessel structure to understanding the activity within those vessels. It feels like a fundamental change in perspective.
It really is. It opens a door to more personalized medicine, potentially intervening before irreversible damage occurs. Proactive vascular care.
Absolutely. And, it makes you wonder, thinking beyond vascular disease, how will this ability to visualize molecular activity transform how we approach preventing and treating other conditions too?
That's the big question, isn't it? What other biological secrets will new tracers or even more advanced imaging tech unlock? It's a field moving incredibly fast, and the potential still feels enormous.